welcome to the latest episode of Open Minds. And again, we've got two fantastic guests. And first, we've got Rona Strawbridge, who is a colleague of mine at Glasgow. And we've also got Manveer Sahota. And Manveer is going to talk about some of his own experiences of having diabetes and maybe that comorbidity of diabetes and anxiety. And I'll be really interested in just looking at how bringing together, crucially, research and lived experience is so important as we not only plan research, but also looking at how what we can do with big data and data science more broadly can hopefully help people in the real world beyond the sort of the lab and beyond the computer of Rona's high-powered computer to do the analysis. So welcome. Thanks, Rona and Manveer, for joining Craig and I today.
Oh, you're welcome. It's my pleasure.
Thanks for inviting me.
Welcome.
Great. So we're looking forward to our conversation. So what we tend to do with the podcast is it's just a conversation, and we're really going to start with your journeys. Each of you have your own journeys and why you're on the podcast today, and really then we'll move into the sort of science and the big data stuff. So Rona, maybe can I start with you? Obviously, we were in the same university, in the same school of health and wellbeing at Glasgow. But for our listeners out there, can you tell us a bit about your journey? I know your journey, but others don't. So tell us a bit. I know you started in biochemistry, so let's take it from there.
I studied biochemistry and got very interested in genetics and genetics of diseases. I spent a lot of time doing research on obesity, diabetes, and heart disease before starting to look at mental illness. I was honestly shocked when I saw the life expectancy difference between individuals with and without mental illness, and the fact that a lot of that is driven by cardiovascular disease or heart disease was surprising, because we have so many preventions for heart disease. Why is it not working well in those with mental illness? So that's my main research question, and trying to understand what the link is between mental illness, diabetes, obesity, heart disease. And yes, there seems to be growing evidence that there's a true biological link. It's not just how people with mental illness experience life and their lifestyle factors.
And so, okay, we'll come back to the science in a second, Rona. But so you obviously started in biochemistry, and then you moved. You did that in Cardiff, like in Wales, and then you moved then to the Karolinska in Sweden. So how did that journey happen?
After my degree in biochemistry, I found a PhD position actually in prostate cancer predominantly at the Karolinska Institute in Sweden. I also ended up doing some research on the genetics of diabetes at that time. And when I finished my PhD, the diabetes was what interested me more. So I found a research position that continued to look at genetics of obesity, diabetes, heart disease. And yeah, that's what I find very interesting. And there's a great need for better understanding of this area.
Oh, fantastic. And we'll come back in a second looking, because I'm keen to explore that, because you obviously were highlighting the early mortality and that or the multimorbidity or comorbidity of mental illness and physical illness and the role of cardiac disease. But let's maybe just go to Manveer first to get a bit of background on Manveer's story so far. So Manveer, can you tell us a bit about your background?
Yeah, of course. Well, diabetes has very much been my life. I've been a type 1 diabetic since I was 1 year old, which is obviously very young to be diagnosed. I'm now sort of in my 30s, so it's been a long time. And I've suffered from sort of mental health problems from the age of around 16. As a result of a major hypoglycemic attack, which triggered it, and life has essentially never been the same since. And that was around nearly 20 years ago now.
Well, I'm really sorry to hear that. And so, if I understand correctly, with that's in those late teens, that's 16, 18 time. So I mean, anxiety and depression were challenges for you.
Yes. So the anxiety attack started sort of soon after that incident, or panic attack straight out. I mean, it was horrific. I went to the point of becoming agoraphobic, and yeah, my world just would kind of been turned upside down really from that one traumatic incident, because I thought I was going to die in that incident. I really did. And it happened on a train in India as well. So, not exactly the best place.
No, certainly not. No.
And then that was one trigger. And then at 19, another trigger, something completely unrelated to health, unfortunately, caused me to have a mental breakdown, which then that cocktail then of diabetes, anxiety, and depression was, I guess I call it the unholy trinity, really. It's not been easy.
Yeah, no, certainly not. And did at that stage, did you have any sense of the relationship between the diabetes, so your physical health, and your mental health?
I guess I'd call it an inkling, as in I had some idea that not just with diabetes, but in general with sort of long-term chronic illness, that there is a connection. And then on my research over time, I happened to read somewhere that it's, again, this isn't I didn't see it backed up by any hard data, but it was saying that we're 3 times more likely to have, diabetics are 3 times more likely to have mental health problems than someone who isn't. So that's how it kind of started to get more solidified within my sort of knowledge base. Yeah.
I suppose that's we'll return to Rona in a second, but I suppose that's one of the important messages of this podcast and this importance of dissemination of this kind is trying to get the message out there, that the nature of that relationship of physical health and mental health, and this odd distinction we make between the two, this arbitrary distinction between physical health and mental health, but also the importance of the research and the sort of the big data work, which is helping us hopefully understand the nature of the relationships, and then obviously hopefully over time then develop treatments, both pharmacological and psychosocial treatments, to help and support people as they, as you say, navigate real challenges. And as you said, things haven't been the same, sadly, since your teens. Maybe to go back to Rona now. Rona, obviously your current title is whatever, UKRI Innovation Fellow, and that work is been trying to really, well, I didn't know about, actually, I didn't know your PhD was in prostate cancer and diabetes, so really interesting, obviously, with Manveer today. And I know your big focus now obviously is in cardiometabolic stuff. So maybe you tell us a bit about the work that you are doing now, and because you really speak to what Manveer has highlighted. I know Manveer talking about diabetes and mental health, but in terms of cardiac health and mental health, can you tell us a bit about some of that work and maybe some of the precise statistics you said about the early mortality?
Yes. So when I got the opportunity to start looking at mental illness as well as physical illness, with this early mortality in those with mental illness, I thought it was very important to try to understand what the link is, and if there is the same biology underpinning mental illness as well as heart disease or diabetes or obesity, maybe some of the treatments that we have for the physical conditions can be repurposed to improve the symptoms of those with mental illness, as well as then preventing some of these longer term complications. So traditionally, people have collected studies, information from people about when they had mental illness, when they had physical illness, and used that to try to understand the link. But one can affect the other quite significantly, as Manveer has mentioned. If you use genetic data, cancer's an exception, but genetic data is fairly stable. So if you can identify genetic markers of one disease, you can look at them, use them to see which direction the causal effect is, which condition comes first. And with cardiovascular disease, heart disease, diabetes, obesity, it really does look like the link is going in both directions. It's not that you have a physical condition and it causes a mental condition, or the other way around. It really does seem to go in both directions, depending on your environment, your lifestyle, stressful life events, all sorts of things.
But so can I just interrupt there for a sec, Rona, on the bidirectionality stuff, are you saying, so are we saying that or so do we have any idea which direction is stronger? I suppose is my first question. And then the second one is, you mentioned there that the genetic component is relatively stable. So is that because obviously, because we know of epigenetic effects, but they obviously are more associated with early life. And my understanding that's correct. So can you maybe just on both of those points, the first point on the strength of directionality, and then maybe the stability of the genetics?
Well, the strength varies a little bit depending on which study you look at. But the fact that there is a very strong link suggests that actually there is something that's underlying both diseases. And it could be, so one theory I have is if your cardiovascular system, if your blood vessels are not functioning particularly well, then that's going to have effects on your heart and how well your heart is working. But also the small blood vessels in your brain are also not going to be working optimally. Mm-hmm. So that's the kind of example of where one mechanism can be having effects on both the brain and the rest of the body. So using genetics is useful for trying to untangle how this is happening. In terms of epigenetics, to be honest, that's not an area I get into. Okay, yeah. There are a lot of environmental effects, but the data I work with doesn't have that information.
Okay, no, I'm sorry, there's an unfair question. It just struck me as you were speaking, that was all. So sorry about that, Rona. Just what thing just dawned on me, just for our listeners, is could you give us a definition of cardiometabolic disease, which you obviously talk a lot about in your research, but what is that?
My definition
is
obesity, diabetes, and heart disease. The combination is very hard to separate those three conditions because they interlink so much. If you can imagine there being, say, 30 different pathways that influence all of them, maybe 10 affect heart disease and obesity, and 10 affect obesity and diabetes, and 10 affect diabetes and heart disease, then which combination each individual gets is very hard to untangle.
Yeah, that makes sense, perfect sense. Rona, asking you again, just more on the big data stuff. So we'll do a bit of a deep dive maybe on work that you're doing currently. But before we go into that, I'm always curious as when we talk about big data. I mean, it's obviously one of the big buzzwords, and in the UK, there are obviously now national organizations really to help us maximize the impact or use of big data, but also the challenges and their challenges and opportunities. So could you tell us about your experiences of using big data and what you see as the sort of both the major opportunities and the challenges?
So I've worked with small data sets, so small in terms of the number of individuals included in them, who have extensive amounts of data available. That is the old-fashioned version. That's what I worked with during my PhD and my postdoc research time. Nowadays, things like UK Biobank have started up, and it's been a huge development to be able to have huge data sets with huge amounts of information about each individual. So for the first time, we actually have a data set that is big enough, that has enough individuals in it with enough information about both mental illness and physical illness. Previously, you had one or the other. You had a data set with physical illness or a data set with mental illness. Having a huge data set with everything you could possibly want to know about any medical condition for a large number of people has been a massive step forward in what we can do. So now I'm able to use one data set where everybody is assessed in the same way, has the same information available, and importantly has genetic data to be able to answer these questions. When you have small data sets, you are limited on what you can do, especially if you want to look at something like sex-specific analysis, because we know there are differences in men and women, how they experience all kinds of conditions. So the big data is fantastic. Going back to the smaller data sets, organizations like HDR UK trying to put all the data together in a harmonized way so we can start to use these smaller data sets, because people have given their time and their data. It's a shame to not be able to use it. an organization putting all the data together to try and make it continually more useful is absolutely fantastic and very, very valuable for a researcher like me.
Mm-hmm. Yeah. And then what about the challenges then?
So a major challenge that I'm aware of at the moment is getting data from individuals with mental illness. There are a lot of barriers to participation in studies. One is trust.
Yeah.
Talking about anything in your health is a scary thing to do. Mental illness and all the stigma and possible biases against people with mental illness makes it really hard for people to trust and give that information. There's also engagement. Somebody might want to participate, but if they wake up and they're having a really bad day or they're having a psychotic episode, participating in a research study is not high on their list of priorities.
Yeah.
So we really do lack good information about the people who are most sick, people who most need the help.
Yeah, yeah. So the generalizability, I mean, of some of these data sets obviously is problematic. But I suppose it can that obviously limits some of the questions you can ask. So, for example, in prevalence, it's really difficult to ask questions on prevalence if you're systematically either consciously or unconsciously, or there's obviously bias. But it still, of course, doesn't stop us asking other questions when you're looking at mechanistic work, like
Absolutely.
you do. Yeah.
Also, research in mental illness is learning a lot from research in physical conditions. So for diabetes research, traditionally we looked at people with and without diabetes. That's great, but it limits how many people you can find who have diabetes who want to participate. You can start to look at features of diseases that are present in the entire population. So for diabetes, we might look at individuals who don't have a diagnosis as diabetes, but we look at their insulin levels or their glucose levels. In the same way, we can do a similar thing with psychiatric disorders or mental illness. So we can look at whether individuals experience anhedonia, and plenty of people without a diagnosis of a mental illness periodically just they experience anhedonia, which is loss of pleasure and something they normally enjoy. So being able to learn from the physical conditions to better ask questions and better find data to work with for the mental conditions. We're getting there. We're making progress.
Yeah, so on that, then I'm going to bring Manveer in and get about this specific project. So you've been doing work, you mentioned there, on the genetic link between mental illness and diabetes. So so can you tell us, to a lay person, what you found, or maybe not so lay person?
So one of our recent findings is that, again, anhedonia, the loss of pleasure in things you normally enjoy, and fasting insulin levels, so a measure of how well your body is handling glucose and dietary energy, they share about 30% of the genetic regulation.
Oh.
So it really does look like there is something going on that's regulating how you use energy and how your mood is reacting to that or causing it. Yeah, it could go both ways. So I was very excited to talk to Manveer and ask him sorry, Rory.
No, go, fire away.
To ask, to what extent do you find that your mood and how much insulin you need to take, how does that vary? Do you notice any patterns?
Oh yeah, no, I definitely do. I find that generally because I am somebody who does kind of go on that, I guess I call it the tan graph, you're literally my mood kind of goes from up to down, constantly changing, and like the extremes, I guess, even, and either way, whether it's very stressed and kind of in the hyper, I need more insulin, because the sugars are generally going up because of the adrenaline and all the other sort of chemicals that are flowing in that state of mind. And it's interesting though, like this has been a more recent thing, I guess. I've noticed more of because usually before it wasn't the case for me that in low mood I necessarily felt that same thing, because you're in the hypo state at that point. I mean, emotionally, obviously not, in terms of a diabetic hypo. And I find that now I've needed, when there's been continuing sort of patterns of that, so if it's been like not just a brief spell and actually more like, say, an entire day or a few days of really low mood, I've noticed that I've started to need more insulin, which is something that is a bit of a change for even me, you know.
And so when did you start to notice that change, Manveer?
Only within, just because I've been under so much stress in other areas of my life in the last year, I've noticed it maybe in the last 7 months, I'd say, more so.
And then maybe I have a question then back to Rona on that. So always, Manveer obviously has established that relationship, confirms the relationship you found in your data. But have you looked at then like an activation effect? Is it stronger under periods of stress, or can you tell that from your data? Can you do that sort of moderation or interaction analysis?
It is something that I've thought about and wondered how best to approach it. So it's on my radar, and I'm trying to figure how you statistically model that with the data that I have available. I do remember discussing with a colleague who's a psychiatrist and saying people with bipolar disorder feel like they have a huge amount of energy or no energy. Can we test that? Can we do glucose tolerance tests when people are have the mania phase versus the depressed phase? And he said, well, practically it's not going to work, because the patients, if they're in the mania phase, they're not going to want to come to the clinic. If they're in the depressed phase, they're not going to want to come to the clinic. And if somebody is emotionally unstable, then depriving them of food to be able to do the testing is just not okay. So there are things I would love to do that just aren't feasible. I keep trying to find ways that are feasible and humane.
Yeah, no, that's so. So has nobody looked at that question you've just mentioned there, Rona?
Not that I'm aware of.
Yeah, okay. And I suppose the whole thing came to my head there when both of you were just speaking was that, right, so what your contribution, Rona, has illustrated is the importance of that big data, or small data but deep data, whatever way you want to describe it, or really, really rich data. But then it's trying to then map that on. Do you do any of the qualitative work, Rona, that tries to map any of that on to, like, so what Manveer has just told us obviously supports what you've said, but he's raised this other issue of actually maybe it's more now because I've been under stress. So
it's something I've thought about. I don't do any qualitative work at the moment, but now that I'm in touch with Manveer, he might get pestered by me lots with questions like this, because I do find it interesting. I read a lot of science, but I don't necessarily see the human side of things. So I'm really happy to have this opportunity to meet Manveer.
Right.
Yeah, sorry, this is really interesting actually you say that, because again, this is I've noticed that now myself, that I know the qualitative side, having the lived experience, but I'm not on the data side. So we're kind of, it's almost like we're two sides of the same coin, really.
We should definitely be in more contact, but
I think so. It sounds like it could be beneficial to us and a lot of people out there as well, I think.
No, absolutely. I think, well, I mean, obviously that's one of the great advances in the last 10 or 15 years, is that central role now of lived experience in shaping all aspects of the research agenda. But then that brings me to a point then, which we've touched on a bit in the context, though, of a diversity issue around these big data sources or small data sources, but these in terms of quantitative repositories, often quantitative data repositories, is what else can we do, though, to try and ensure we have diversity? Because UK Biobank, we know, is a great resource, but we know it is only represents, largely speaking, a group of people who tend to be more likely to be middle class and of a particular, and maybe more interested in their health and so on. So have either of you any ideas on what else we can do in terms of diversifying or improving diversity? And I'll just say one thing before you jump in, because we're having another discussion, Craig and I, with another guest, and they had an idea of just part of, and she was just speaking personally about, she never used to include or answer questions about ethnicity when she, as an individual, and if she was asked in a clinical context ever, or to her GP or whatever it may be. And she said that's because she's from an ethnic minority background herself, and in some way she associated it with some that would lead to maybe barriers or trouble. But then as she progressed in her career, her view was no, but it's really important that we collect this data, in her case around ethnicity, because and her line was, if it's not counted, it's not important, right? Or you can't demonstrate the importance without counting the data. So that's one way she thinks of trying. So her advice was, we're trying to improve diversity, we need to ensure the general population, general public recognize the importance of data. So with that sort of provides a little bit of a long way around to getting back to asking the question. So have you any suggestions what we could do, both from a lived experience perspective, Manveer, or Rona from a research perspective, what we could be doing to try and ensure diversity, that we do get inclusivity in our data? Rona, maybe go to you first, and Manveer, you second. Rona?
Sure. I just hope I'm not talking too much. I think it's important to give the message out that, especially considering genetic data, what we know is based so much on European ancestry, because that's the data that's the easiest, that has been historically the easiest to collect, but it limits what we know. The European ancestry accounts for perhaps 8% of the global population, so we're missing a lot of information, and the data that we have is not useful to everyone. I think making it more, or giving a better idea that actually it's important for everyone to benefit, everyone has to participate and contribute. Easier said than done. Yeah. I'm well aware of that. Yeah, over to you, Manveer.
Yeah, no, that's an important point. Manveer, and or maybe another way to ask a question of you, and I don't mind how you answer it, is if we were advertising for a study on diabetes or whatever, or mental health, would you take part, first of all? And then secondly, if you were reluctant to take part, are there things that we could do to make it more likely that you would say yes?
The interesting thing about me, not only, I guess, would you say in general, but in terms of even within my sort of ethnic sort of my community as well, I'm different in that I'm very open and willing to partake in such things. And I'm happy. And I think it's because health has been my life. Yeah. You know, that's why I'm interested in sort of all round, you know, in general, and like studies like and research like this that's being done, for example. But I mean, there are, I can be honest with you, even now, like just thinking about it, there are a lot of people, not only in my community, my sort of ethnic community, or even within the diabetic community that I know, who would, as you know, Rona said about difficulty with, you know, finding participants, people just wouldn't want to talk about these things. You know, they really wouldn't. And that's the honest truth. You know, I've learned that from experience. And even if I've been open, people have even not been so comfortable to even reciprocate with me on that personal level. So if I'm really thinking about it, I'm not unless you really, like you say, just try to encourage people as much as possible, I'm not sure what else could be done. I mean, I know diabetics even who hardly ever go and see the doctor, you know, and people who are, so that's just, and even other people I know who aren't diabetic who won't even go for their once a year physical, you know. It's so it's part of a bigger problem of trying to change people's attitudes towards health in general, you know, and about looking after yourself and then wondering and so forth. But yeah, I can appreciate the challenge, and unfortunately, even after everything I know and all the knowledge I've gained, I'm not sure how one could change it, because that it's also within my community as well. There's that, it is that cultural thinking, you know, as well. And not only in terms of just the way that people view their health, but mental health is still, it's a very, very backwards view when it comes to mental health. People, I mean, I know so many people who still think, even like relatives of mine who think, you know, you only go to a psychiatrist if you're you know, if you're crazy, you know, essentially, or you take antidepressants for the same reason. It's almost like there is still that shame in it, you know. So it's part of a much, much bigger picture here of what you're dealing with. So, and I know this is like they're trying to collect the data is one small facet of that, which is just going to be a great challenge from everything from my lived experience.
Yeah, and I know Rona's trying to come in. No, I think that's a point really well made, Manveer, is although we are making progress in terms of tackling the stigma and the shame and so on, but I think we're going at different speeds with regard to different mental health conditions and people from different backgrounds, and that's not just ethnic minority backgrounds. That's a whole range. I mean, I also looking at socioeconomic background as well. So I think we have a lot to do there. Rona, you were trying to come in there when Manveer was chatting there.
I was just wondering if making it more obvious, because I don't think the general public are necessarily aware of this biological link between mental and physical conditions. If we can make it more clear that the two are very tightly connected, you cannot separate the two. maybe people who are more concerned about their physical health when in later life, whether they'll enjoy their retirement, for example, whether that would encourage participation for mental illness or mental health research as well.
No, absolutely. In a way, that sounds so simple, right? And I agree entirely with you, right? But trying to do it, because if I think back, I think that if we go back to, I think I might be wrong in the precise year, but the World Health Organization, I think in 1948, came out with a statement about there's no health without mental health, or that idea that we have to see these things holistically. Right, and obviously, hopefully, I'm not so far out, but it definitely, my memory was 1940s, right, 1948, and we still see these things as first of all dichotomous, sadly too often, and as you say, Rona, the work that you're doing and others are doing is seeing the genetic commonality that underpins both of them, and of course, there's huge environmental influences as well, of course, but it's recognizing that these are all, it's just about health. And it's, to my mind, I think it's a much more healthy way to go. And it might, as you say, it may help with dealing with the stigma or challenging the stigma around mental health in particular. No, two really useful observations. So we're sort of coming to a sort of close here. So I'm just trying to have a couple of last questions for you both. So we touched on the sort of inclusivity and diversity around data, and there has been great progress in these big repositories now to try and move things forward. But I think what the conversation here has highlighted is the importance of bringing up that big data is all well and good, but how do we translate it into our everyday lives, and the importance of implementation science and all these things. But Manveer, you touched on about things that help. I mean, in terms of your own individual, the impact on you individually. Your mental health. So for me, I always think it's useful in this podcast to find out what works for each of you in terms of sort of the implementation bit is, what do you each do in your everyday lives to hopefully manage your own mental health or look after your own mental health? So maybe start with Manveer this time. Manveer, what works for you?
Well, it's interesting for me. It's actually been sort of 15-year journey now, really. So it's changed a lot over time, essentially. But there's some things that are, I mean, essentially, I've tried every therapy under the sun. You can think I was in every modality when I say therapy, you know, in terms of psychotherapy, psychiatry, psychoanalysis, CBT, I've done it all. And well, the one thing that did help, which I've done for the most time now, well over a decade, is psychosomatic and sensory motor psychotherapy. And I can say to that, the extent of the help what it's done for me is essentially saved my life. Like, I don't think I would have been here today had I not found that, you know, all that time ago.
And what does that involve? I'm less familiar with that. What does that involve?
I was just about to ask the same thing.
Sorry, Craig.
Well, the base theory of it is that essentially it was developed by a doctor called Dr. Peter Levine, and the theory of it is that trauma isn't necessarily all in the mind; it's also in the body. And so, like animals in the wild, they, depending on where they are in the food chain, they can be under threat from a predator at any particular point. And they have their fight or flight response, you know, and so once they escape that situation, their nervous systems are naturally built to discharge that pent up energy that they get in that situation. But we as humans aren't. Our nervous systems aren't built that way. So essentially, to put it primitively, the gunk builds up in our nervous systems. And that's what can then lead to things like, you know, addictions and, you know, physical health problems and, you know, even twitches and, you know, just different physical manifestations of unprocessed trauma, which is what I had plenty of, not just through my health concerns, but even other aspects of life where I've suffered a lot of trauma too. So I had a whole cocktail of things that essentially were inside me causing all sorts of problems. So it's essentially been through seeing a therapist who deals with that particular type of therapy where I've managed to get a lot of that junk out of my system which has kind of saved my life, really.
Okay, fun. I mean, I will Google that afterwards or look more into this. I'd never heard of that. So, and just to say, we're so glad you are still here, Manveer.
Thank you.
And then maybe on to Rona. So what do you do to look after your mental health?
For me, regular exercise, even though I might hate going for a run, is very beneficial. And I spend as many weekends as possible hiking in the middle of nowhere. So getting away from the city, getting into somewhere green, that makes me happy.
Yeah, no, and well, living most of the time in Scotland, Rona, obviously that's easier for us in this great part of the United Kingdom, obviously, of our access to the good outdoors and the hills is great. Okay, so one last one. Oh, sorry, Manveer, you're trying to come in there.
Yeah, sorry, there were a couple of other things I was going to mention.
Yeah,
if that's
yeah,
okay,
fire away,
if
yeah.
I can just add on. Another, I mean, obviously that's the kind of core thing that's helped me, the therapy that I mentioned, but there was also, I use sort of quite a few sort of, I'm quite into alternative medicine, so I do use things like CBD oil, for example, which, you know, has had a big push in recent years and become a bit more mainstream, I think, which has really helped with just generally calming nerves and with even some of the psychosomatic pain that I've had in the body, you know, where, I mean, some points I've ended up in A&E with that pain. It's been that bad, you know, and this oil has massively helped me where nothing else could, no other painkiller could, for example. And it also helps calm the nerves overall and the anxiety. And also I do partake in homeopathic medicine as well, which has helped me in certain aspects where sort of allopathic medicine hasn't been able to. You know, so I take that holistic approach that you mentioned earlier, and I do try anything and everything that I feel might help, and I'm pretty open-minded when it comes to those sort of things.
Yeah, great. I think that personalized approach, I think, is really, really important. Okay, so thanks for that. One last question we try and ask all our guests is, and maybe I'll start with Rona this time. Rona, so reflecting on, you're a bit older than 16 now, I think. So, so what advice would you give your 16-year-old self? And it could be on any aspect of life. It doesn't have to be mental health related. What reflecting back, what would you wish your 16-year-old self had known?
That's a really tough question.
You've got a head start here, Manveer, to try and think of yours.
Yeah.
I think a motto I came up with when I was doing my PhD, actually, and I talked to my supervisor who was into diabetes research, I said, so if I eat well and sleep well, everything will be fine. She's like, pretty much. So that's what I try to stick with.
Yeah, so obviously basic homeostatic function, if you feed or you maintain that, and obviously both of those will help with that. Yeah, so that's really solid advice there, Rona. Manveer, what about yourself?
Yeah, well, if we're talking sort of in terms of the overall picture, I would say, I mean, yeah, to use a generalized cliche, I would just say expect the unexpected is one. But if I was getting more specific to my personal situation, I would just say don't get on that train. You know, yeah.
Yeah, well, yeah, well, both of them obviously. Well, we'll try and the expect the unexpected one. I think I like that. I really like that one because that's one way of us trying to give ourselves a false sense of control over events if we expect the unexpected. And then well, I would say hopefully there are different trains we can get on and bring us to better destinations. I think that's maybe the way to try and end this. So all that remains for me is a huge thank you on behalf of Craig and I for taking the time to join us. I really thought that worked really well together, obviously hearing about Rona's great science, but also from Manveer, your perspective on how that science makes sense. And it really highlights the importance of these different approaches in terms of that detailed quantitative data assessment, but also how, if we're trying to move all fields forward, it takes these different approaches with different voices. So huge thanks from Craig and I, and enjoy the rest of your day. Thank you.
Thank you.
Oh, thank you.
Thanks.